Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, welcome to Clinical Clips. I'm Dr. Ioana Preston, and I'm the Associate Professor of Medicine at Tufts University School of Medicine. In this first episode, we'll be reviewing exciting and new data presented at CHEST 2024 from October 6 and October 7. The first presentation of interest focuses on the impact of metabolic disease in pulmonary arterial hypertension. It has been reported that carnitine levels in PAH are low, and the authors hypothesized that the carnitine metabolism is altered. In order to study this topic, the authors measured carnitine levels and also measured nutrient intake in an initial period, after which patients with PAH had supplementation with carnitine, and the levels were measured again. What the authors found was that carnitine levels increased after oral supplementation, suggesting that nutritional deficiency is not probably the cause of carnitine deficiency and alterations in pulmonary arterial hypertension. Further studies to better understand the deficiencies and abnormalities in the carnitine metabolism in pulmonary arterial hypertension would be very interesting in the future. The next topic focused on how to predict pulmonary hypertension in patients with pulmonary fibrosis or IPF. This study looked retrospectively at the cohort of patients with IPF that were enrolled in Artemis IPF study. This was a large multi-center placebo-controlled randomized study that enrolled patients with pulmonary fibrosis. So this particular retrospective study looked at 4 variables in order to assess their ability to determine their prediction of the presence of pulmonary hypertension. These very important non-invasive parameters were the ratio of forced vital capacity and diffuse DLCO, oxygenation during a 6-minute walk test, race, whether it was white or non-white in a binary way, and the distance during the 6-minute walk test. And these 4 non-invasive parameters were assigned points that the worst combination points were added to 100. And it showed in a discovery cohort and a second validation cohort, the area under the curve for the prediction, for this prediction model was 0.75, suggesting that clinicians can have this Ford model in the clinic in order to predict the presence of pulmonary hypertension before sending patients to the right heart catheterization. The next presentation was a review of pulmonary hypertension in interstitial lung disease, its prevalence, the current definition, as well as the updated treatment algorithm. And it highlighted the changes in the definition of pulmonary hypertension in ILD as suggested by the 7th World Symposium on Pulmonary Hypertension, which includes the disease such as ILD, COPD or emphysema, chronic pulmonary fibrosis and emphysema combination, and so on, rather than the abnormalities in the pulmonary function tests. So this is an updated definition. Second, the presentation focused on highlighting the prevalence of pulmonary hypertension in interstitial lung disease, and also the impact on survival with higher mean PA pressures and higher pulmonary vascular resistance being associated with worse prognosis. And lastly, the presentation focused on the treatment algorithm of pulmonary hypertension associated with interstitial lung disease, reviewing the increased multi-center data that showed improvement in 6-minute walk distance with inhaled treprostinil, which has been already approved by the FDA for this treatment, but also evaluating the new study on 20 Japanese PH patients that showed significant improvement in pulmonary hemodynamics with inhaled treprostinil in an open label study. And the talk concluded with highlighting the complexity of the diagnosis and also the difficulties sometimes of making an accurate diagnosis of PH group 3 associated with interstitial lung disease, and went over the recommendations for treatment of patients with PH-ILD. The next session of interest focused on pulmonary hypertension in sleep disorders, and the presenters reviewed the fact that there is a very high prevalence of sleep disorders that have associated pulmonary hypertension, anywhere between 20 to 30 to 40%. And then the presence of pulmonary hypertension is higher if the sleep apnea is more severe, if there are other comorbidities, and if patients are more severely hypoxemic even during the day. The presentation concluded with recommendations to actively screen patients with sleep apnea for the presence of pulmonary hypertension, because it does correlate with outcome, and it suggests that a more aggressive treatment of sleep apnea should be implemented. Lastly, focusing on pulmonary hypertension in a different lung disorder in COPD. This session and the speakers focused on the prevalence of pulmonary hypertension in COPD, and they highlighted the fact that the pathophysiology of PH in COPD is quite different from interstitial lung disease, and it's probably due to significant and total destruction of the pulmonary vascular bed rather than an inflammatory change in the pulmonary vasculature that we usually see in interstitial lung disease. And they reviewed the data of the treatment of pulmonary hypertension in COPD, and they highlighted the scarcity of clinical trials that we have in this entity. The meta-analysis and retrospective studies and very small randomized controlled trials. So overall treatment of PH in COPD, there are not a whole lot of data, but we hope that future studies will bring us more effective treatments. Thank you so much. Please join us on Wednesday, October 9, for episode number 2. To download the slides and access other related topics, please return to the landing page. Thank you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.